Hello, everyone, and welcome to our South Texas Regional Family Medicine Grand Rounds. Our educational partner today is the South Central Area Health Education Center. Our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. Okay, sorry. Thank you in advance for muting your microphone once the presentation begins, being attentive to the presenter and engaged in the session, keeping cameras on when appropriate, registering for CME credit for each session, and for completing and submitting a session evaluation form. Today is March 13th, 2024, and today's activity code for CME credit is 1009-3240. If you have not registered, you can text your email address to the toll-free number on the screen, 844-502-1338, or CME credit via text, and then text attend 1009-3240. And this is just some information about that new CME system, CME credit via text. Again, today's code for March 13th, 2024 is 1009-3240. You can access your CME transcripts from the Long School of Medicine CME website using the instructions on the screen. I'll leave that up for just a minute. American Academy of Family Physician members can use your AAFP login and claim credit for this activity online via their credit reporting claim credit system. This live activity, South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to 1 prescribed credit by the AAFP. Physicians should claim only the credit commensurate with the extent of their participation in the activity. The Family and Community Medicine Grand Rounds is to address the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS ACGME competencies, and the AAMC competencies. Our speaker today, Dr. Curtis Bone, MD, MHS, has no financial relationships with ineligible companies to disclose. Dr. Nato will now introduce our speaker.
Well, it's a pleasure to introduce Dr. Bone. Dr. Curtis Bone is an assistant professor of family medicine and a board-certified addiction medicine physician at the Dwell Institute on Substance Use and Related Disorders. He completed his medical training at Johns Hopkins School of Medicine, a master's degree in epidemiology at the Bloomberg School of Public Health, residency training in family medicine at UCLA, and fellowship training in addiction medicine at Yale and the West Haven VA. He has practiced clinically in FQHCs, OTPs, primary care clinics, as well as in incarcerated settings. But also, he has a longstanding interest in education and research. He has been repeatedly recognized for educational excellence and published a number of peer-reviewed manuscripts focused on substance use and related disorders, such as chronic pain. Dr. Bone, welcome.
So thank you for that very kind introduction. Really thrilled to be here today to speak with all of you. And yeah, to talk to you about chronic non-cancer pain management, applying the family medicine model to optimize outcomes. And I'll be honest with you, I don't love pain, but it's important. And so I've spent a lot of time thinking, talking, and learning about pain. And so what I'm hopeful you'll be able to do at the end of this conversation is differentiate acute from chronic pain and pain intensity from pain interference, to apply the family medicine model to implement best practices for management of chronic pain and limit negative outcomes for patients and providers, and also to utilize buprenorphine for management of chronic non-cancer pain for patients who are already opioid dependent. Just to give you a sense of the outline, I'll plan to spend about 15 minutes, 10 to 15 minutes with each objective, and then leave plenty of time at the end for a question and answer session that will involve a patient. I want you all, just so in the interest of time, if we can hold questions till the end, that would be ideal. So I'm going to try to move through some of the material relatively efficiently. All right, so we'll dive in, differentiating acute from chronic pain and pain intensity from pain interference. So how big a problem is pain? Worldwide, the burden caused by chronic pain is escalating. It affects about 1.9 billion people across the globe. More than 120 Americans are living with chronic pain, and it's the leading cause of disability, costs the US an estimated $600 billion annually. So it's a problem, it's a common problem, and it's something that will often show up in your office, right? Something that we are asked to address. So what is pain good for? Why does it exist? It's ubiquitous because it's adaptive, right? So acute pain exists. It's provoked by a specific disease or injury. It serves a biological purpose. It's self-limited. It's the ascending pathway that's affected. And what I tell people is that our brain needs to know if our face is on fire, right? Pain is a warning system for our bodies. If there's an injury and repair is needed, then our brain or bodies need to be aware that that healing's occurring, and we need to be gentle with that space in order for healing to really take place. And as we're aware, if pain doesn't exist, patients have problems, right? Diabetic neuropathy, for example, causes tremendous morbidity and mortality. So pain is an important biological system. It's complicated. It's sort of the warning network for our bodies. And in general, when it's acute pain, it should be addressed with pain control, rest and recovery. Mobilizing may be necessary. Opioids may be appropriate, right? So important to realize, we hear a lot about opioids and how they shouldn't be prescribed, but realize they have a place. And with an acute injury, opioids may be the ideal treatment. So what is chronic pain? All right, chronic pain may be considered a disease state. It's pain that outlasts the normal time of tissue healing, generally considered greater than 3 months. Nerve transmission still occurs along pain fibers, but instead of only going in the ascending pathway, the descending pathway is also involved. So signals are more centralized, less protective, may arise from psychological states, serves no biological purpose, and has no recognizable endpoint. Movement is often an essential part of treatment, and moving through pain becomes critical to maintaining wellness. In this setting, opioids may lead to hyperalgesia. They do not improve long-term outcomes. And so just to kind of remind ourselves of this pain pathway, right? So we have some sort of injury that occurs, substance P, inflammatory cytokines will be released and move along our D fibers. They're going to cross over, ascend in the spinothalamic tract. Modulation is going to occur at the periaqueductal gray, and then you're going to have communication with the somatosensory cortex. So that's something that says, hey, my finger is injured, right? There is also the descending pathway that's really active in chronic pain. You can see sort of the central sensitization that occurs in that image in the upper left corner. So that is primarily mediated by serotonin and NMDA receptors. So this is more of a psychological experience, but it's something that people feel, right? It's just communicated from our central nervous system down to the periphery, as opposed to being communicated from the periphery up to the central nervous system. So a case. This is the case. How would we treat this? This is acute or chronic pain? Acute pain. What are you going to do for this person? What's that? Okay. Pain control, right? So in this situation, it's an open fracture. It's an emergent surgical situation. Give them morphine, 2 milligrams IV, and titrate to effective pain control. Transition to short-acting oral medication based on the morphine equivalents that you derive from your IV needs. And then as healing occurs and pain reduces, wean over the course of 2 to 4 weeks. That's how we'd want to approach this. So when do you want to use full opioid agonists? So acute tissue injury, broken bones, severe ligament strain or rupture, malignancy, ischemia from a vaso-occlusive crisis, like sickle cell disease, post-op for pain control. You could think of additional examples, but these are reasonable times. But what occurs, right, after surgery, and when does it become more challenging? So this slide shows you that about 20% of people end up on opioids 3 to 6 months after a traumatic injury that required surgery. This is specific for neuropathic pain. You can see that far more people, 20.5% of patients end up on opioids as opposed to a medication for neuropathic pain after a surgery. So how do we approach this? So again, if you're going to start an opioid, realize that there may be some people that end up with chronic pain. They may request longer duration. So my advice would be get a contract at the start, check the PDMP, avoid early refills, Realize doses generally should not escalate. There shouldn't be continued tissue injury, so you shouldn't need more opioid over time. If you get into a situation where you're managing a chronic opioid, a UDS at minimum every 6 months is recommended. And then you'll want a confirmation UDS if there's clinical uncertainty about the screening study. So there's a result that's not concordant with self-report. You may want a confirmation study. And then to limit harm in these situations, you want to avoid prescribing things that are at an increased risk of overdose when used along with an opioid. So important to realize benzodiazepines increase risk of overdose when co-prescribed with an opioid about 5-fold, Lyrica about 3-fold, so 2.82, baclofen 2.5, hypnotics 2.29, and gabapentin 1.49. So you may run into patients or run into these experiences where patients are co-prescribed these things. You may feel a little stuck. We can talk about how to sort through that, but we certainly don't want to start them down this road. So what are our other options? How good are non-opioids at treating pain? So this is a review article that assessed the literature and found RCTs that used non-opioids and for both acute and chronic pain. And I think it's probably not super easy to see this unless you're at home. But what it shows is that most of these studies don't show a profound effect. They show that NSAIDs have a moderate effect on pain intensity, and the skeletal muscle relaxants also have a moderate effect on acute pain. When looking at chronic pain, you see a moderate effect from NSAIDs and a moderate effect from tramadol. So nothing that really jumps out and screams, hey, I'm a solution for you. So the question is, are we measuring the right thing? Should we be measuring pain intensity at all? So some would argue that pain interference is a more meaningful outcome. So what's the difference between pain intensity and pain interference? Pain intensity is a measure of how intense the pain might be on a scale of 1 to 10. This is a subjective experience. There's high levels of interpersonal variability, and pain scores just aren't reliable for assessment or treatment. Pain interference answers the question, is there anything you would like to do that you're not able to do because of pain? What is pain getting in the way of? Is it preventing you from lifting weights, from riding a bike, from mowing the lawn, from going up and down stairs, getting out of bed, attending social events? What is the functional outcome that we're looking to achieve? And what is the problem pain is causing you? So kind of shared, acute pain, this is how we approach it. You can approach it with non-opioids or opioids, depending on the severity. Chronic pain, what are we going to do? So I'm going to try to make the case that we should apply the family medicine model to implement best practices for management of chronic pain and limit negative outcomes for patients and providers. So what's that mean? So say that focusing on pain interference is consistent with principles of family medicine. And in alignment with that, there's a quote that the individual management of patients with long-term problems has been called the quintessence of family medicine. To provide individual management, the physician must know and understand the patient as well as the disease. The clinical method must be patient-centered. The essence of the patient-centered method is the physician's attempt to understand the meaning of the illness for the patient. Why did the patient come? What are his expectations, feelings, and fears? So what's that look like? It's not asking the question, where's your pain on a scale of 1 to 10? It's trying to understand what the patient's pre-morbid status was. What did life look like before this pain started? What did you enjoy doing? What did you love to do at that time? What are your current streams of joy? What gives you joy these days? And can you tell me about the pain you're experiencing? I want to understand the biological pieces of this pain and what you're going through. Is there anything that pain is getting in the way of? How do you feel about this pain you're experiencing? What's the emotional impact or psychological impact of this pain? And what would you like to do if pain was better controlled? So those are some questions that we can ask to understand the patient and the pain experience. This is all very consistent with the biopsychosocial model, which I would call the family medicine model, because this is just how I was trained to approach patients from a biological, psychological, and social perspective. It turns out that this was first developed by a gentleman named George Engel, who was an internist with a strong interest in psychiatry and the psychological and social impacts that illness has on people. And it's something that has really been adopted by our field. And I think if we apply these principles, biological, psychological, social components to patients, we end up with these questions. So this is my general approach and what I would recommend for our trainees who are managing patients with chronic pain. So what are the benefits of focusing on pain interference as opposed to pain intensity? So pain interference informs our treatment goals. Rather than treating to a pain score of 0, we're treating to a level of pain that's going to help someone garden, a level of pain that's going to help someone get out and enjoy a bike ride with friends or go to a social event with their family. It's a more reliable metric for progress. It sets realistic expectations for pain. It helps people understand we may have pain still, but we want to maximize your joy in life. It also shifts the conversation from a passive experience of pain to an action or idea of action that the patient desires and is working towards. And it can be empowering to focus on what the person can do or what they want to do, rather than focusing all of our energy on pain itself. If I spend an hour just talking about pain, I feel uncomfortable at the end of that encounter, right? But if we're talking about what they want to do or what they're hoping to do or what they're going to do, it's a far more fulfilling experience. And it gives us more meaningful data about whether or not our treatments are effective. All right, so what if we use multimodal treatments consistent with the biopsychosocial model and focus on pain interference? So I showed you, they did all these RCTs, they looked at non-opioids, and we didn't see much of an effect. So what if we actually apply these principles to pain management? What do we see then? So there was a space, they called it a space trial, and it's a pragmatic trial that was done through the VA in 2013 through 2016, involved about 240 people. And essentially what they did is they randomized people not just to Tylenol or to NSAIDs or to tramadol, but to opioid management versus non-opioid management. The non-opioid management group used a stepped approach that started with Tylenol or an NSAID, and then as needed, they would add on nortriptyline or gabapentin, something to impact the transmission phase of that pathway that I showed you. And if that wasn't effective, they might add an SNRI, something that influences modification of the periaqueductal gray, or might impact the psychological perspective that someone's experiencing or the descending pathway. And if that didn't work, they added tramadol, which you might say, hey, that's an opioid. And you're not wrong, but that was sort of the last step, was tramadol. They compared that to an opioid first approach, where their first step was morphine or hydrocodone acetaminophen. The second step was MS-Contin. The third step was fentanyl. And then they looked at outcomes over the course of a year. And what they found is that groups did not significantly differ on pain-related function over 12 months. So pain interference was essentially the same in each of these groups. Pain intensity was better in the non-opioid group, 4.0 versus 3.5. So you may say, well, what's the difference there? And I would say there's probably not a significant difference, although the stats would disagree with that. There were fewer adverse medication-related symptoms in the non-opioid group than the opioid group. So equivalent outcomes, less adverse effects in the non-opioid group when people took this multimodal approach, which we can say is an application of the biopsychosocial model, or what I would call the family medicine model. And so just to kind of summarize, this is what this looks like. So again, there's an injury, transduction occurs where substance P, inflammatory cytokines are released at the site of the injury. In order to address that, we'll want something that acts at that site, like an NSAID or Tylenol. And then we have transmission, right? In order to impact transmission, we'll want an anti-nerve agent. That could be gabapentin, that could be Lyrica. Then there's modification. In order to address modification, an SNRI, a TCA can be helpful. And then there's the interpretation. And you all heard about non-pharmacologic interventions to help with pain, right? That's where CBT, acceptance commitment therapy, that's where all that helps. And then the descending pathway can be intervened on with SNRIs, and exercise movement actually helps modulate all of that as well. So you can think about it in this way. You can use an outside-in approach. That's the model that I was taught. Use something topical, use a couple of oral agents that intervene along this pathway. If we still don't have pain control, you might think about more invasive things like joint injections, and then your last step might be surgery. This is all, and then your other kind of external things would be things like CBT, physical therapy, adjustment if you're trained in those techniques. But all of these things can occur before we think about ascending to an opioid. So, okay. Oh, I think I'm going the wrong direction. Here we go. All right. So the other thing that I like to share with people is that if we use a multimodal approach, we're also going to have less risk of adverse outcomes because we're more likely to be operating in that therapeutic window. If we are intervening on multiple pathways at the same time, I equate it to multiple hands trying to lift a car. If it's just one person trying to lift the car, they're likely not going to really get the lift that they're looking for, the movement that they're looking for, and they're more likely to get injured, as opposed to lots of people lifting at the same time. You're going to get better therapeutic effect with less risk of injury. And that's just because at higher doses, we have greater risk of side effects. So lower dose agents, multiple agents at the same time, is likely to reduce your risk of any sort of adverse effects. All right. So here's a case. This is a patient that I saw in clinic. 47-year-old presents to clinic complaining of pain and numbness in the right lower extremity. She reports pain is 4 out of 10 and was brought to clinic at the behest of the front desk because of concern for this pain. Pain has been present for 3 years since the birth of her child. It's intermittent, it's burning quality, precipitated when she stays in a specific position for too long, and it's relieved by changing position. She does not feel the pain prevents her from completing ADLs. It does not prevent sleep. It doesn't wake her from sleep, does not disrupt work, impair ability to care for her daughter, or prevent her from engaging in activities that she enjoys. She smokes 1 to 2 packs of cigarettes a day. Great. So I was seeing this patient along with a provider, and he said, well, what do you think we should do? She has neuropathic pain. Should we give her gabapentin? Do you think we should give her Lyrica? These are options. And what do you think we should do? I said I would do nothing. She has 0 pain interference. This isn't bothering her. The one thing I would do is help her quit smoking, because that's likely driving a lot of the neurodegeneration and potentially some of the inflammation that's contributing to her pain. But you do have people that will jump when they hear pain, they'll think medicine, because that's kind of what we're trained to do. If there's a problem, we have a medicine for that. And these are medicines that are listed as neuropathic pain options, treatment options that I found on Medscape. So what you see here, gabapentin, Lyrica, amitriptyline, duloxetine as our first-line agents. You see opioids listed as a second-line agent. I really wouldn't think of opioids in that space, but people will start people on opioids for neuropathic pain. So what do we do in that situation? This is the same case in this situation. However, our patient's unable to wash dishes, do laundry without severe pain. She finds it challenging to fall asleep, and the pain is waking her from sleep. She's fearful of exercising or playing with her daughter because of pain. So exact same case. In this situation, we have pain interference. How would we approach this? My recommendation would be utilizing this multimodal pathway, something topical, an anti-inflammatory, something for nerve transmission, gabapentin, Lyrica, Flexeril, and then something for the descending pathway, an SNRI, and then really focus on smoking cessation. And then lastly, like we said, we'll have people that are starting folks on opioids. How do we approach that? So what I want you to understand is how to utilize buprenorphine for management of chronic non-cancer pain for patients who are already opioid dependent. All right, so in this we have the same situation. However, this person was prescribed oxycodone. They've been on 30 milligrams 3 times a day for the last 5 years. All right. So why should you consider an alternative like buprenorphine? There's an article published in 2012 by an oncologist who gave 12 reasons, his top 12 reasons to utilize buprenorphine as a first-line agent for cancer pain, not non-cancer pain, but cancer-related pain. And his first reason is it's effective for cancer pain. His second reason is it's effective for treating neuropathic pain. Third reason, it treats a broader array of pain phenotypes than most other mu-opioid agonists, than full agonists. In addition, it's less constipating than full agonists. There's a ceiling effect on respiratory depression, so someone's less likely to get hurt from buprenorphine than full agonists. And people have less cognitive dysfunction when they're on buprenorphine compared to full agonists. So the whole experience is better. So you can get an equivalent analgesic effect, you have a safer prescribing experience, and people tend to feel better. The other really nice thing that I'm going to highlight is that it's extremely long acting, and tolerance does not develop with buprenorphine. With methadone and buprenorphine, people don't become tolerant. They can stay on the same dose for years and years and years. Their body might change and they might develop more pain, but the medicine's not going to change their body in the same way. So that's really, really critical. In part, that's because it has this exceptionally long half-life. It lasts about 38 hours in the body, and sometimes, some cases, 25 to 70 hours, which is also nice for people. They don't have to take something over and over and over throughout the day. Other nice things, so you can use it in situations when someone is opioid dependent. You can use it in situations when someone has an addiction. You don't have to figure it out. Is this addiction? Is it just pain? If they're opioid dependent, they can benefit from buprenorphine. There are still risks. It's an opioid, right? So sedation, overdose is possible if they're on other sedating medications. I showed you the list. Benzodiazepines, baclofen, gabapentin. We still have to worry about that, but you can worry less. It's going to be safer than what they're already taking if they're on a full agonist. All right. However, I don't suggest it as a first line for someone that's opioid naive. Right? So that's really important. If someone's already opioid dependent, this is going to be a better medicine. If they're opioid naive, I'm very, very hesitant to start something that starts something like buprenorphine. So why do I have this slide up? So the AFP says that family medicine is strong medicine for Americans. So I'm going to try to make the case that buprenorphine is a strong medicine, because when I started working with it, I sort of felt like I was selling snake oil. And subsequently, I've really come to learn that it's an opioid and it's effective. So these are systematic reviews of randomized controlled trials that show the effectiveness of buprenorphine. The top one is folks that have addiction, and it's 5 studies. And you can see pretty clear movement away from that central line that shows no effect with treatment. And then on the bottom is a summary of studies for folks just with chronic pain. And again, you can see that buprenorphine, there's a measurable benefit to utilizing this for people with pain. When they compare buprenorphine to morphine, you can see that over the course of 6 hours, they found better pain scores with buprenorphine compared to morphine in this study on the left. And on the right, they compared buprenorphine to fentanyl, morphine, oxycodone, and found pretty much equivalent outcomes regarding pain intensity. And I can attest, I've had plenty of people on fentanyl that I converted to buprenorphine and found their pain was as well controlled and their experience was better. They've done studies on patients with sickle cell disease. This is relatively new. So this was 36 patients. They converted them from full agonist opioids to buprenorphine. At 6-month follow-up, 84% were still on the medicine, which means they didn't revert. Their visits to the emergency department reduced from 10.5 to 2.89. So far better pain control, far fewer pain crises on buprenorphine compared to full agonists. So this medication is effective. So how do you start it? People use this word induction. I don't like the word induction because it sounds like you're going to intubate someone, but basically you need a washout period. You need to wait about 4 to 5 half-lives before you start the medication. You can do that by figuring out what they're on and then calculating it. You can also give them a scoring sheet, a SOWS score. It's a subjective opioid withdrawal scale, which you can Google. They score on their own, and then when they get to a 12 or above, they start the medication. If someone has pain and they don't want to start the medicine because they're going to be in pain, I'll have them come to the office, give them a shot of Toradol, and then we can start it that night. And then there are ways to start it for folks that don't want to go through withdrawal at all. This is called a microinduction protocol. Essentially, you slow build the buprenorphine over time. When you get to a meaningful dose of buprenorphine, you reduce the full agonist by half, and then you convert completely to buprenorphine. So that's a nice option for people. Important to realize there are different formulations. I had a provider that transitioned his patient from a fentanyl patch to a butrans patch. The difference is dramatic. He felt like his patient had developed opioid disorder because he started chewing the fentanyl patches that he had. So he didn't develop opioid disorder. He was on 300 morphine milliequivalents and you converted him to 1 morphine milliequivalent. So it was an issue with dosing. So realize that butrans patches are very low dose. Films are going to be higher dose. So the patches are in micrograms, the films are in milligrams. The published conversion from buprenorphine to morphine milliequivalents is 30 morphine milliequivalents to 1 milligram of buprenorphine. In my personal experience, my training, I use a conversion of 10 morphine milliequivalents to 1 milligram of buprenorphine. So if our ceiling on buprenorphine is 24 milligrams. We can get equivalents with 200 to 240 morphine mill equivalents, if that makes sense. So if someone's on 100 morphine mill equivalents, I'll imagine they'll do well on 10 milligrams of buprenorphine. So it gives us a lot of flexibility. I'm happy to talk more about those things, but if you want to learn how to use buprenorphine and you're not super comfortable with it, first of all, come spend time with me at Be-Well on your rotation. Having a great time with the residents that are there. There are also ways through CSTAT, through Be-Well, you can get registered, prescribed buprenorphine. We have some flyers up here. If you want some additional training in that more specifically, there are echoes that are running. And yeah, that's essentially the story. So the goal today, differentiate acute from chronic pain and pain intensity from pain interference. I hope you understand the difference between those at this point, and that you'll be able to implement best practices to avoid high-risk practices to limit negative outcomes for patients and providers. So that really is just to avoid co-prescription of full agonist opioids with these things, benzos, Lyrica, baclofen. And also would really encourage utilization of multimodal management, try to intervene on all of those steps in this pain pathway with some sort of agent. Think about the outside-in approach, use a topical, use an oral, think about physical therapy, CBT, ACT, to get as complete a treatment approach as possible. And then would really encourage utilization of buprenorphine if opioid dependent or concern for opioid use disorder. So those are my references. And I recognize that these are numbers